Welcome to Dinet Discussions, a speaker series. My name is Ellen Driscoll. I'm the president of the board of directors for Dinet, the Dysautonomia Information Network. For anyone who is not familiar with us, we are a nonprofit volunteer organization dedicated to enhancing awareness and giving support, education, and information to people living with POTS and other forms of dysautonomia. Joining me also from Dinet is Lauren Malak. She is the vice president of the board of directors.
Hi, everyone. Thank you for joining us.
So Lauren and I are also both living with POTS, so we know this subject quite personally. Before we begin, I would like to give a special thanks to our sponsor for this entire series, Banana Bag Oral Solutions. They offer products that give people the benefits of the nutrients and IV hydration therapy without the need for the IV. It's specially formulated for people who have chronic illnesses like POTS. So at the end of the video, if you check the video description, there will be a link to Banana Bag to their website, and I encourage you to explore their site and learn more about their products. Today's session is the first of a four-part series that will continue through the month of October into the first week of November. And today's presentation is Get in the Know, an overview of POTS today with Dr. Amer Suleman. Dr. Suleman comes to us from the Heartbeat Clinic in Texas. He is also the adjunct professor for the University of Texas, Dallas. Dr. Suleman is a cardiologist, a POTS specialist. He is also certified in internal medicine as well as electrophysiology. We are very grateful to have him as part of Dinet's medical panel advisory team, as well as being very grateful to have him here with us today for this presentation. Hello, Dr. Suleman. It's good to see you. And I will turn over to you, and we will be back with patient questions at the end of the session. We hope you all enjoy.
Thank you. Yeah, I just want to clarify one thing, that I was certified in internal medicine, but I gave up that certification. So I'm mainly cardiologist. Of course, we got the training. So for everyone here, I see my students here, I see some patients. This talk is directed towards, budding doctors, POTS patients who are interested in the field. And this is basically an overview of the POTS today. The practical aspect of this talk is that I want everyone to benefit from this. So no matter how small, it could be something as this, that it started an idea or a research idea in your mind. It could be something that you are suffering from and you may get an idea, or it could be something that I added to your knowledge. A quick thing, levels of evidence in medicine. In medicine, there is a level 1, level 2, and level 3 evidence. Level 1 evidence is something that is quote unquote proven science. Level 2 evidence is where there are some studies. Level 2B is if they are case series, and level 3 evidence is that is dangerous. So it is very important to understand that there is no level 1 evidence in POTS. There is no proven science that should be considered standard of care. So most of the management is just based on the available science, what we know today. The first question that patients would ask is, do I have POTS? Now, many times, you will say, I get dizzy when I stand up. That is exactly not equivalent to having POTS. There are other conditions that can mimic it. One is, of course, POTS or postural tachycardia syndrome. Another thing that we see very commonly, and I coined the term POI or plain orthostatic intolerance. It is also called deconditioning syndrome by others. There is an old name to it before even POTS came in, like when I was in training. It's called beta hyperadrenergia, but it is basically orthostatic intolerance or lightheadedness that does not meet the definition of POTS. Like you go on a tilt table and you get dizzy, but the blood pressure drop is 18 points, or the heart rate increase is not 30 beats per minute. And so if we talk about it, we still consider in the same bucket that this could be POI. Of course, there could be orthostatic hypotension. There is a demarcation. Orthostatic hypotension sometimes would improve and patients will have POTS. Sometimes it will be alternating, but for all practical purposes, orthostatic hypotension should be considered a different entity. And it has its whole set of causes. For example, orthostatic hypotension can occur in diseases like Parkinsonism, or orthostatic hypotension can occur in amyloidosis, and you don't see that in POTS. And then, of course, there is a less known entity, but well-described orthostatic hypertension, where actually the blood pressure goes up on a tilt table and people get dizzy. It is something that we should be aware of, because the common thinking is that when the blood pressure goes up, the circulation goes up. And so there is something, a small concept of cerebral systemic uncoupling that is a reasonable assumption in day-to-day life. So that is a reasonable assumption that whatever is happening with your blood pressure is the same thing that's happening in your brain. So if you think about it, the blood pressure is actually measurement of circulation in your arms. You measure the pressure of blood that it exerts on blood vessels in your arms. And it is an assumption that whatever is happening in the arms is happening in the brain. So for example, you can look at one tire of your car and say, yeah, it's in bad shape, and make an assumption that all three tires are in bad shape. But that may not be always true. There may be something else going on that is keeping the blood pressure up, and you have cerebral systemic uncoupling, meaning the perfusion pressure or the blood circulation to the brain is actually going down. And as I said, we do see it quite a bit where patients are told, you don't have anything. You don't have any drop in blood pressure when you stand up, when actually it could be a case of cerebral systemic uncoupling. Remember, when you get up, other things happen too. Your head moves in one direction. So you can have different types of vestibulopathy, where actually what's happening is not a drop in circulation to the brain, but some type of balance disorder with the movement of head. And patients are thinking they are getting dizzy when they stand up. And then, of course, there can be hyperventilation syndromes that if you do carbon dioxide monitoring during your tilt, you will actually see it quite a bit. And in complicated cases that usually, sometimes people like us get involved, there are actually two things going on. So there is a patient, and the most common two things are some type of orthostatic intolerance and some type of vestibulopathy or a balance disorder. This is something that most of people know. How is POTS defined? It's a heart rate increase of greater than 30 beats per minute within 10 minutes of standing or upright tilt, 40 beats per minute for teenagers. There is a question whether upright tilt and standing are equivalent. And there are a couple of studies on this. One was done by us, and I think another one was done by Harvard. And it critically says that usually upright tilt will see more patients of POTS. So the question is whether you end up overdiagnosing POTS by doing tilt, or whether you end up basically picking more. You are just, so the simple answer to that is that based on my personal experience, you don't overdiagnose. However, that's a good thing for the students. That's something to be looked at. If you take a patient where the heart rate, and we do stand test on all our patients, and we do tilt table also. So the delta heart rate with standing versus tilt, a good point to look at is that if you see someone with delta heart rate of 20 beats per minute on standing, but 39 beats per minute on tilt, and you treat them as POTS, do they get better? My general experience is they do. However, that will be a good research topic for the students. And of course, definition of POTS involves no drop in blood pressure. And another thing that is commonly used is symptoms lasting for more than 6 months. That can get very tricky. For example, we know that COVID can cause POTS type symptoms. And are you going to wait for 6 months to diagnose POTS on a COVID patient because someone had COVID and 6 weeks later is still dizzy? Or are you going to do some type of treatment? The general consensus, what I'm seeing in the studies, is that people treat. So if there is an ongoing pathological process that can only get worse, or delaying treatment for 6 months may just make things worse, many doctors will say treat, and you can see it online also. There were actually program on CNN. Doctors started immediately on the exercise program once patients develop spots. And I think as long as you don't cause any harm, that is a reasonable approach. But definition of POTS does involve a time duration of 6 months or more. What are the associated conditions? Joint hypermobility, muscle activation disorder, balance disorders. A common question is to ask patients is whether you run into door frames. Are you clumsy on the field? And most of these patients actually, they are not synonymous. So it is not like they are dizzy with POTS and they run into door frames. They will run into door frames even if they are not dizzy. So there is a question whether it affects the sense of proprioception. And as I always tell my patients, this is not normal. So for example, if everyone runs into door frames, then we should have just bigger door frames. So we shouldn't have, so if some people do and some people don't, and that is, we will talk about it a little bit, but then I would consider it. And if you do CTSIB that we will discuss in a second, there is the, you will see that balance issues are actually very common in POTS. And one of the common things when you're treating a patient with POTS and 80% is better is still dizzy, they're probably running into some type of balance disorders. Other things are gastroparesis, depending on which study you look at, and actually depending on how you define. So if you go with the classical definition of gastric emptying less than 10% in 4 hours, not that much, but if you look at pattern of emptying, you will see it is different in POTS patients, and we have written some papers on that. Abnormal HIDA scan, similarly, it is actually a personal opinion and personal observation. I don't know how much else, but we do see in a small study that we looked at 220 patients who got gallbladder surgery, around 1/3 of them did not benefit. So that's just my study. So others may have different experience. Median arcuate ligament syndrome, that's a hot topic. I actually rather would quote my own paper that I quote a 50% success rate. Originally, when males came in, people were reporting 70%. They are still reporting 70%, but I'm just quoting my own data, my own patients. Nutcracker of renal vein, we see very commonly. At least there is one paper or one abstract out there that helping fixing nutcracker helped POTS. May-Thurner syndrome, similarly, they are case series. Some of them have been written by us, but we do see having severe May-Thurner, but there are no double-blind studies. You may be seeing a placebo effect. Thoracic outlet syndrome, similarly, we see it quite often. Whether it contributes to POTS or not, but it definitely contributes to tingling, numbness, and features that patients have. We use ultrasound to diagnose it. Uterine vein congestion was originally described by John Hopkins, and there is actually quite a bit papers that were written on this subject. The long and short answer is that there are no double-blind studies, but uterine vein congestion, also known as pelvic congestion, if you fix them, it can help POTS. And of course, Sjogren syndrome, Dr. Goodman has done a great job on this, where treating Sjogren syndrome with Plaquenil actually help POTS. So the answer is yes, I do believe there is an autoimmune cause to POTS, but I do think there are other causes to POTS also, like hemodynamic, and there could be a combination of things at play, and there's an academic argument why we say that. Now, this is a paper that we talked, and this is a paper that actually opened my eyes. So I had a student that I had someone from Dr. Levine's office coming to me, and when we talked about data, they were surprised that we have been having this review of system forms for several years, and they thought it's a treasure trove. We should report. No one has ever reported the frequency of symptoms in POTS and what they have. So I gave it to my student with no special instruction, and what she wrote at the very end practically opened my eyes. And that was her conclusion, but it practically opened my eyes. I never realized, despite treating POTS patients, I never realized the depth of problem. And it says, first time our research demonstrates that persons with POTS experience an average of 32 patients, 32 symptoms. Majority patients of POTS live through these symptoms daily. practically I moved into tears when I saw that, although I was looking at data, but how deep and severe the problem is, I never actually, despite of treating POTS patients, never imagined that this is how common it is, and this is what they live through. And to make it more complicated, I have students who come from family practice background, and they are taught that if you have more than 3 symptoms, consider psychiatric problems. So imagine 32 symptoms occurring in different ways, and basically people are living through it. So of course, we get very passionate about it. And my personal opinion is it's not in their head. And that whatever published researchers say that, but whosoever is listening, it's not in your head. This is a very, very, let me see if I can tell you how many patients we looked at. So let's see. We can say intake 53 symptoms and 1 at a time and 2 to 2. And then we rated them, and out of 155 POTS patients randomly picked up. This is what we found. So there was no selection actually for whatever defense it is. I didn't even tell my student. I just said, just let it analyze it. And her conclusion was just mind-blowing for me, that what they are going through. So even someone like me who sees these patients was just taken aback about the quality of life questions. Imagine you have a leg pain and you are wondering what's going on, and imagine this. This is another small paper that actually we wrote back, I would like to say early days of POTS, like 2008. This is study number 2. There was one done by us a little earlier, and that is at the time where joint hypermobility, well, it's still a little controversial, but it was very controversial. So we looked at the heart rate change in patients and see how flexible they are. So if the theory nulls hypo, and we put them in 3 groups, and people who were not flexible at all, and see, long and short answer is that the heart rate change actually corresponding with how flexible they are. So I think it was back in 2008, I would like to say we were one of the first ones, if not the first one, who described this relationship of joint hypermobility with POTS. And, and it was subsequently. So now Dr. Levine wanted to do a study on this that I think never got the grant, whether it's the elasticity of the vessel. And I use this example of the giraffe. So if you were to look at a good anti-gravity mechanism, think of a giraffe. So giraffe C has small legs, very tight skin, so blood cannot pool in the legs, and a big heart. That's where Dr. Levine's protocol is, where you improve the heart size to improve the function of POTS. And then there are valves in the artery so the blood can travel all the way up. So imagine a giraffe has a lax skin. So these legs, rather than having this tight skin, actually have very relaxed skin, like joint hypermobility. So all the blood will pool in the leg and the giraffes will start fainting. And, for lack of, as I said, there is no level 1 evidence, as I said originally, but that's where the whole idea of exercise comes in. And that's where the whole idea of having compression stockings and all those things come in. Now, as I told you, there was a study to be done by our good friend, Dr. Levine. I don't think they ever got the grant. And it's very difficult to find patients for this study because valvular disease in the veins are common. So how can you put it solely on the elasticity of vessels and not valvular disease? But then you can have one leg in one patient that has valvularly, okay, and the second leg in the same patient actually doesn't have valvular disease. So you can use, and I'm just giving this idea for others to listen to. And if they want to research on it, to see how much blood pools in the legs and whether it has to do with elasticity of the vessels or the valvular disease or both. Now, this was a question that you guys asked me. So this was a study that we published for Arnold-Chiari malformation. The answer is we did not find any relationship of Arnold-Chiari malformation with joint hypermobility, but we did see increased prevalence in patients with POTS. And the delta, the Arnold-Chiari, so let's say if your Python score is 9 versus 5, at least in a small study that we did not find that adrenal carry malformation was more when you were more flexible. This is a case report that I'll talk about before. We actually reported it first time using albumin in POTS. And there are some more studies to follow. We did it in 2010, probably the first one. At least that's what we claimed. But fact is that there are some studies ongoing on the subject. This becomes very helpful if you have Meniere's disease, because as you know, salt can make those things worse, and giving IV albumin can work both ways. This is a concept that I just mentioned about heart being strong and tachycardia-induced cardiomyopathy in POTS patients. So bottom line is that you have to have a very, very compliant heart that takes the blood and pumps it out. If it becomes bigger, for any reason that we saw sometimes it does, and the changes are so meniscus that you can only pick up on a reset. So like left ventricular internal diameter will go by 1 millimeter, and that is within the observation error. And again, Dr. Levine has done great work on it doing MRI. But long story short, you can have inability of the heart muscle to pump blood. And theoretically speaking, COVID can be doing something like this. As we always say, and I quote Dr. Goldstein here, ideas are cheap, research is expensive, but this is a point to be looked at. Now, diet-wise, high sodium, high protein diet, hydration. We use different supplements, a common thing that people can do. Others will be more like, I don't want to give names because of the commercial interest, but you can make your own salt capsules. They are easy to do. And you can also put salt in whatever you eat. I suggest high protein because as I showed you that picture of the giraffe, I want strong leg muscles in POTS patients. Many other people who treat POTS would agree with me. However, as I mentioned, there is no clear-cut data to the best of my knowledge. Similarly, hydration is important. And as you and I talked about before conference, I think Satish will be the right person to talk about it. But yes, there are a lot of ideas, in everyone's mind, looking at renin-aldosterone system. We actually have looked at it indirectly in tilt table test, and there is inactivation of renin-aldosterone symptom in some patients. So when they are standing for a long period of time, they're just, the renin-aldosterone system does not kick in. As I mentioned before, Dr. Raj will be the right person to talk about it. Exercise. So basically, you can do two things, customize your standard protocols. Dr. Levine has done a great job, show his job protocol. And of course, you're allowed to have a personal bias. Customized protocols, I think, do work better. This is a chapter that I wrote back in 2017, even when I started before, and it talks about exercise prescription and the benefits for it. And these are the things that a common exercise prescription should include: type of exercise, specific workloads, duration and frequency, intensity guidelines, and precautions. But I do fully understand that it may not be possible for everyone to get. But if nothing is working out, you have been given a standard protocol and you are not getting anywhere, you may want to consider this. Many times we do our exercise prescription, and I can pull up, we have a small paper on that, using cardiopulmonary stress test, and we kind of focus on the anaerobic threshold. And many times the generic protocol doesn't work in our patients, but then we are also seeing a very, very complicated population. It may work for most of them. But that's a good general description that you want to keep for yourself for the exercise prescription. Medications, keep in mind there is no level 1 or even level 2A evidence regarding medications. However, there is consistency in observations. For example, there are a lot of patients with avebradine and COVID POTS. So we see that, but no one has done good double-blind studies with all the good and bad. But midodrine can be used. in our small population that we have, we gradually up-titrate the dose. Many times you just give one dose, like 5 milligram 3 times. I find in my small population that up-titrating is a good idea. My students or others can look into it, but my general feeling is we don't end up using 5 milligrams 3 times. Many patients require a higher and lower dose. So maybe generic is not a good idea, but as I already told you, this is a personal observation. Droxidopa I've used in POTS. In the study that we presented, they were like 50%. 13 patients with difficult POTS, 6 benefited. Cafergot is my personal observation too. I've used it in very complicated cases with great success. But these medications should only be given by people who know how to watch it and follow it. So just don't go out and ask for a prescription. Pyridostigmine, also known as Mestinon, in our experience, the syrup works better than tablet. However, the published data actually will be more in the, it doesn't matter. Again, my students can do a research on that. But I think in the things that we haven't published, but we have looked at, syrup worked better at a lower dose. And TDAVP, people do use, Florinef, people do use, Vebradine or Corlenor. And we actually reported on it when Corlenor came out, and that's only our studies. But we started with a very low dose of 2.5, and we gradually up-titrated it as opposed to the therapeutic dose of 5 milligram. And long story short of it is that I think you end up using a lower dose. In the study that we did, the median dose, that is the most common dose, was 2.5 twice a day versus the minimum dose of 5 milligram. That is, and it's of course an off-label use. Beta blockers, the message to take home is all beta blockers are not created equal. Some work better than others. Again, as I mentioned, there are no double-blind studies, but there are several case series that will say one beta blocker is better than the other. And they have been studied also. Prozac, I've used it a couple of times. I have a patient overseas, actually from Japan. She actually takes Prozac for POTS and it works. And there is data on that. And personal observation on digoxin, since the recent trial came out on digoxin and it is back in favor. Sometimes I add digoxin to Corlenor. Again, it's a personal observation, should not be considered standard of care, but it worked around 50% of times on top of Corlenor, not alone. Unproven roles, and it's very important because most of the time people think that they are very, very desperate and they are at that point where something drastic needs to be done. And that is mostly not true. Mostly, as I said, you can think outside the box, but first let's do everything that's inside the box. So rather than going to heroic procedures and other things, the things that I just mentioned before actually do help. And mostly they work. There are procedures, like I talked about May-Thurner surgery. I'm not a big fan of Nutcracker. There are studies out, but remember, those are case series. And it's very controversial about MALS and POTS or uterine vein congestion or May-Thurner. And, it just happens. I've reported quite a few of those case series. And I'm telling you, looking in your eyes, that there is no proven rule. This should be used as last resort. Cryotherapy is something patients consider. Again, to the best of my knowledge, it's not quote unquote harmful. It basically causes vasoconstriction and the benefit will last. But these are unproven rules. Keep that in mind. Head up tilt sleep is actually more in line. Patients do that. Tilt training is another thing you can do. There is a small tip. You can buy an inversion table and that's very inexpensive, like $150, $200, and you can use the upright position of the inversion table for the tilt training. And if you get dizzy and someone is next to you, the table can be flipped back so you don't faint. So that's something like a small tip. And then, of course, something that should be done in people who are experienced in it is combination therapies, combining 2 medications. This is a paper that we wrote back in 2010, I would like to say. This is on enhanced external counterpulsation in POTS, in actually not POTS, in orthostatic intolerance. And basically, in our small study, it did work and it does have a theoretical background, but the reason I brought it up is that I recently have patients that have tried it at another center, and they also agree that it works. So we did it on our POTS patients. It works like an IV fluid, except that you don't get stuck. And, so as I said, these are unproven therapies, but out-of-box ideas. And keep in mind, you have to do what is inside the box before you start thinking out of box. Now, other things that people don't commonly try, but they are worth trying, midodrine plus mestinon syrup actually works very effectively. Florinef and midodrine works well. Florinef and Corlenor and midodrine works well. And many times the devil is in the details. It is the dosing. It is how you are given. It is what beta blocker is used. Were you given the common dose of Corlenor, or were you just given 5 twice a day? So those small details sometimes make a huge difference. Volume expansion is another thing. IV saline as bridge therapy can be used, and I'll talk about it, but I don't recommend IV saline as destination therapy. And then, of course, IV albumin that we actually, I want to just put my name to fame. As you can see, it was presented in 2010. So I'd like to say, as we say, this is the first case report of using albumin. And I think when we did our research, it was the first case report, but since then others have reproduced similar results. The benefit of albumin is that it works better, and then the benefit lasts for 3 weeks as opposed to 1 week. So if you are stuck with IV fluids, it will save your veins. However, remember I said it is not a double-blind studies. There are double-blind studies to be done. The IVIG trial with the POTS, the placebo arm has albumin, so there will be things out there. However, we did, as you can see in this particular patient, everything was tried. This was my first patient, and she did exceptionally well. I was surprised. It was, my own, I just brainchild. I just woke up and said, let's try this. And we reported it in 2010. POTS in pregnancy. Again, it also goes to the personal opinion, but it has worked very well for us. We should publish it. That's another idea for students. But we stop the medicine and use saline up till 20 weeks, and it works like a charm. So rather than, whether this is indicated, this is C class, this is B class in pregnancy, should it be continued, mess with the dose, patient is still having palpitations. I just find it very simple. Most of patients do well with POTS in pregnancy, and those who don't, that's what we do. And as I said, I don't think anyone has published it, and I encourage the students listening. That's a very, very, in my experience, it works. But keep in mind what I said before, these are not class 1 evidences. And at last, I will just say this is from Allama Iqbal, Poet of the East. It's in Urdu. And what it says, Khol kar aankhein mere aina guftar mein, aane wale daur ki dhundli se ek tasveer dekh. And what it translates it, that open your eyes the way I look at things and think about future and all the possibilities that are available in future, rather than being stuck in a cocoon and not think beyond. So take the ideas and think over it. So I think that finishes my talk, and I'm all ears.
Very well. Well, thank you so much, Dr. Suleman. And Lauren, you have some questions now for him?
Yes. So let me just switch screens here. Okay. Dr. Suleman, do you mind stopping your shared screen?
I will do it right now.
Thank you. So the first question is, can you explain why POTS patients have cognitive impairment and slurred speech sometimes?
So basically, it could be something totally unrelated. But 2 things that immediately come to mind are cerebral hypoperfusion, like there is low circulation to the brain. And if you do transcranial Doppler in these patients, you will see the concept that I discussed, cerebral systemic uncoupling. So the brain circulation can go down despite of blood pressure being normal. So that could be a cause. There are some research ideas I have. For example, remember I talked about inversion table. So if you put a POTS patient on inversion table and increase brain circulation, will the circulation improve? Something for someone else who is listening, because we don't have enough resources to get this something through IRB. And so yes, so that's one. And of course, sleep. Non-refreshing sleep is very common, and non-refreshing sleep will cause neurocognitive impairment. That's just common knowledge. And then what happens with non-refreshing sleep, you cannot organize with thoughts. There could be other things out there that will be actually not my field. I think you have a neurologist, Dr. Blestin, coming in. I would prefer that she weighs on it.
Okay. So you mentioned in your presentation kind of a wide variety of treatments that you recommend for POTS. And is there any that stand out to you or that you see coming out on the horizon that are very significant to treating POTS, or that you think would be the most beneficial to people to try?
Yeah, so basically, first I want to clarify, did not recommend, just give some personal observations and opinion, and it should be taken like that. There is no class 1 evidence in POTS, as I said to begin with. And I think the best thing that's happening, and we can have a long discussion, but I think autoimmune diseases and POTS that are on the horizon are very, very promising. Because if you look at the venous compression syndromes and stuff, you can argue that someone is born with them. So they should not develop POTS at a certain age. Something else pulls the trigger. So I think on the horizon, that would be the most promising thing that I can think of.
Okay. And believe me, I know this is challenging because everyone's different and everyone's symptoms are different and their level of POTS symptoms is different. But speaking to you saying, about POTS, another question we got from our members was, is POTS genetic?
Yeah, and the answer is that I have families who have POTS, and I have family members who haven't developed POTS, but they are on leading question you will ask, and they will describe orthostatic intolerance. So in my experience, yes. And then you can say POTS is a syndrome. Syndrome means set of symptoms. So the underlying cause may be genetic in certain populations. And then that leads to another question that I think is very important for research is prevention. So if you identify a family with POTS and there is one member of the family who has not developed it, do you do something like hydration, high protein, exercise prophylactically? That is a question. As I said, my whole idea is to stimulate minds, to think about it.
Okay. Yeah, that's very interesting. I know personally for me, I have quite a few family members who have forms of dysautonomia and autoimmune illnesses, just in general. So that's very interesting to think of a way to prevent it for people who haven't had symptoms yet. That's very interesting.
Yeah. I think that's the direction it should go.
Another one we received was, is it possible for a person to have POTS and orthostatic hypotension, not at the same time, but to experience symptoms of both?
It's possible. But POTS by definition, if on a tilt table or a stand test, there is a drop in blood pressure, but there is, let's say, an increase in heart rate, you will call it orthostatic hypotension. They are mutually exclusive in the definition, but we do see it. So especially in the trial that we did on Northera, or I shouldn't have said commercial name, for droxidopa, we found that patients with neurogenic orthostatic hypotension sometimes will not have neurogenic orthostatic hypotension, but only have POTS. And at other times, measurements will be. So I guess there is a substrate like that.
Okay.
And that's again a research idea that should be looked into.
And then the last question I have for you is, there's a community of people who experience POTS later in life and during the time around menopause. And have you seen that POTS or dysautonomia is affected by aging at all, or what types of symptoms people in that time of life are experiencing?
That is true that patients usually in older age groups they may not have that much incidence of POTS. So the first thing in that age group is that you should look for life-threatening conditions. So lightheadedness in an older patient may indicate arrhythmia, and that should not be missed, because POTS technically doesn't kill you, but arrhythmia would. So that is a common practical tip for people who treat it. The incidence of POTS is more in the younger folks. And then you can argue that there could be a component of adrenaline that, and then it goes to a huge academic discussion, but there could be a component of adrenaline that is responsible for some of the symptoms. And when you age, the adrenaline levels get better, and some of the symptoms like anxiety just naturally get better. So, but again, older elderly folks is not an exclusion. So you shouldn't look at an old person and say he cannot have POTS or she cannot have POTS. However, as I said in my first slide, things, just the dizziness on standing doesn't mean you have POTS. There are a lot of other things you can do.
And have you, speaking to that, have you seen people with POTS symptoms having their symptoms get worse or better as they age with your own patients? Have you noticed anything significant?
The answer is that I do see some of the symptoms get better, yes. So I do see that they outgrow in their 50s, or the anxiety symptom or the adrenaline symptoms are not as worse. And that's why I said that goes to the whole discussion whether adrenaline or heart rate is playing a role in POTS. And that goes to the question, how does Corleone works? Because technically it shouldn't work. And then, so the answer to that is simple, yes. And it should be looked at. There should be more research on that subject. Okay.
Well, thank you so much. I really appreciate you taking the time to stick with us and answering these questions. It was very, very helpful and educational.
Yes, I agree. Thank you. Thank you so much, Dr. Suleman. It was a wonderful presentation. I learned a lot, and I keep thinking that I'll get to a point where I already know everything, but it's not happening. It was fascinating.
That's what I want to stimulate brains.
Right.
So I want people to think, and rather than just saying that these are 32 symptoms and there is something in their head.
Right. And I did find the paper that you brought to our attention about how many symptoms we are living with daily, just in the course of our day-to-day life. It almost brought tears to my eyes thinking about that, because it is, you get so used to a level of how you get through the day and all the little tricks and tips that we've learned to work within, that you don't realize it's staggering to hear that number of symptoms in a day. Even things like the losing the balance. And when I almost laughed out loud when you said about people crashing into walls, because I do that all the time. You know, I'm just so used to it that I don't even think of it as a symptom anymore. It's just the way I walk, you know. So I think it's very interesting.
Again, you know, we can talk about patients teach us as much as, you know, for example, again, it's just a patient observation, but proprioception is affected. But let's say if you can use heavy bangles or heavy watch, so your brain knows where your arm is. It's not using sense of position. It's actually using your tension receptors.
Right.
And all of a sudden you will notice you don't run into door frame. That's just an observation.
Right. That's what I mean. Yeah, it's fascinating to from a patient perspective to hear these things, because I mean, we obviously agree that the more research and the more that people think outside the box, as you said, is what makes the difference in our quality of life, because we then, you know, have better treatment options. We learn different things that we can do, even in sharing patient to patient, as well as the medical profession sharing all this information. It's really a wonderful thing. I appreciate so much you being here to teach us all. I just want to, in concluding, I just want to thank everyone else for attending the session. I want to thank Banana Bag Oral Solutions again for sponsoring. And I would like to remind everyone that next week, October 19th, will be the premiere of our next session, COVID-19 and Dysautonomia, What is Known and What is Not, with Dr. Svetlana Blitzstein. So on behalf of all of us at Dinet, we hope you enjoyed this session, and thank you again, Dr. Suleman. Be well, everyone. Thank you.